Good evening, everybody, and we welcome you all for this global webinar on poverty, hunger, and disability, the missing link. I request Professor Nicholas Nisbett to talk to us. So Professor Nicholas Nisbett is a senior research fellow at IDS, where he co-leads the health and nutrition cluster of researchers and teaches on development and nutrition. His work explores the political economy of nutrition policy and programming in South Asia and Sub-Saharan Africa. And he has published research on national and international nutrition governance and policy process, community level drivers of nutrition, and community accountability. Professor Nicholas will talk to us on global food security and nutrition inequity. Over to you, Nicholas.
So I'm just going to start by giving a very quick overview of malnutrition across the world. Forms of malnutrition such as child stunting are still prevalent across many low and middle income countries. Stunting means children not growing to their full potential. So this is a condition which reflects chronic deprivation, and it's associated with higher rates of illness and preventable deaths. Likewise, wasting is still prevalent in many countries at a static or even rising level. And wasting reflects rapid weight loss or inability to put on weight, and this is often as a result of crises or seasonal deprivation. On top of this, COVID contributed to the largest single-year increase in global hunger in decades, and we still don't know the full extent of this impact other than it has been large. And now this is combined with a number of drivers of food price inflation, including Russia's invasion of Ukraine. It's expected that these pressures will not only drive food insecurity, but will also push many more millions of people into poverty, exacerbating the cycle of poverty, inequity, hunger, and malnutrition. And it's important to realize that in discussing malnutrition, that we're also now talking about high and growing rates of obesity and overweight across low and middle income countries. Now, it's really important to remember that most children suffering from overweight and obesity are not located in the wealthiest countries now. 45% of children with overweight and obesity are living in upper middle income countries, 31% in lower middle income countries, and 10% of children with overweight and obesity are living in the poorest countries. So those are the basic stats on malnutrition globally right now, but I wanted to look a bit more at inequity. Socioeconomic inequity has always been associated with nutrition outcomes. In some countries, the gap is narrowing, as you see in some of the countries listed along the bottom of this slide. We have Peru, Ghana, and Mongolia. But in some countries, the gap is actually widening, and this includes some large countries such as Nigeria, where you see that around 18% of the rich population, parts of the population have the stunting rates amongst the richest part of the population are around 18% in Nigeria. But amongst the poorest populations, the rates of stunting are around 63%. Now, some of the best work in this field is providing excellent resources on equity in outcomes, but also coverage of health interventions known to affect nutrition. For example, support for exclusive breastfeeding. And these data are often disaggregated by both income and gender or geography, including most commonly urban and rural differences. But there is still limited focus on inequity that goes beyond income differences, including the wider social determinants of health, such as racism and ethnicity and disability. Some of this work is being carried out here and there. Here, for example, is research by the UK's Food Foundation, which looks at the different experience of food insecurity during the COVID pandemic for people with long-term health and disability issues, and the difference for those who are from a Black, Asian, and minority ethnicity in the UK, and those who are coming from the predominant white communities. And again, you see the differences in food insecurity there as a cause of the COVID pandemic. In many contexts, when you drill down in the data, the broader inequities do stand out starkly. So here are data, for example, from NFHS 5 in India, which is a recent demographic and health survey that's covered all Indian states. And you see here in Odisha that rates of stunting amongst children in scheduled caste and scheduled tribe groups stand out at much higher rates than for other caste groups and other communities. So to try to conceptualize the reasons behind such differences, myself and my colleague Jodie Harris at the Institute of Development Studies were commissioned to try to come up with a new framework for the 2020 Global Nutrition Report. This was updated with the help of other experts on food and health equity and indigenous food sovereignty, and was published recently as the Nutrition Equity Framework. The framework mixes a number of key existing frameworks, so the UNICEF framework on the determinants of malnutrition, the WHO framework on the social determinants of health, work on political economy, so looking at in whose interests are institutions shaped and in whose interests are resources allocated. But the key thing we wanted to talk about was what we called the engine of inequity at the center of this picture. This breaks down further the definition of equity to include distributional unfairness. So how are not only resources, but also costs and benefits of action and policy distributed? Political exclusion. What are the processes of inclusion and exclusion from representation, participation, and accountability at all levels? Injustice. What are the daily, lifelong, and intergenerational forms of discrimination and dispossession, for example, from land, from traditional knowledge, that help drive these differentials in people's starting position? The evidence for this is multiple forms. It's not a set of RCT studies, but there are multiple forms of evidence. Some of them are experimental, some of them are correlational, many of them qualitative, and some of which take us to the current horizons of interdisciplinary science, for example, in the links between environmental justice and nutrition. So a number of different studies here, for example, looking at how disadvantaged socioeconomic and ethnic groups might be more exposed to unhealthy food advertising. There's studies here looking at labour market discrimination and how that affects people's lifelong opportunities, which can kind of be related to ableism and racism. There's also studies looking more recently at the links between environmental justice, so how particular population groups are more subject to pollution, and how that links not only to stunting, but also now to obesity. What does this mean in terms of action? In the Global Nutrition Report, we followed the WHO Commission on the Social Determinants of Health recommendation in asking us to summarize and understand the problem from an equity perspective in the first place. Sometimes the data are there in the DHS, such as the NFHS data I displayed earlier, but the data aren't being exploited for those purposes, which is why the work that Monica referred to earlier is so important. Here, for example, is work that Jodie Harris, Fong Hung, and colleagues at the National Institute of Nutrition in Vietnam have done on stunting rates amongst different ethnic groups in Vietnam, but it's still very rare to see this kind of work. But there are a range of other equity-sensitive actions that can be taken both within and outside of the nutrition sector, from universal healthcare proportional to need, and targeted support to marginalised groups, to land and agrarian reform and welfare provision. As one of our co-authors writes, Valerie Bluebird-Jernigan, these kinds of reforms are particularly important when working with groups who have been dispossessed of sovereignty over their land and the cultural and culinary knowledge that adheres to this land. Public health in these circumstances cannot mean coming in with behavioural change and dietary guidance designed by outsiders. It means recognising that control needs to be taken back by affected communities of their food and nutrition sovereignty. So I've raced through, and I'm going to finish up in a second, but I just want to say, when I accepted this talk, I told Venki that I didn't know enough about disability and nutrition links, although we'd started to explore some of this in the context of the Global Nutrition Report and the Nutrition Equity Framework. But I started looking around a bit, And I came across this very useful slide, which is the work of the Disability Inclusion Help Desk, which is funded by UK Aid, and which summarises some of the research and some of the policy-oriented advice on disability and nutrition. And it shows a growing interest in the need to make specific adjustments to nutrition programming and policy to take into account the large numbers of people living with disabilities who are also malnourished. People living with disability wanting to access health and nutrition services often find their way barred due to a number of different factors in relation not only to their disability, but to the prejudice and discrimination experienced by people within society at large. Many of these barriers are easily overcome with a better disability focus in nutrition programming. Some of this might be to do with training health workers, some of it might be to do with the meeting the specific physical or communication barriers that those living with disability may be experiencing. And some of this might be down to different provision for particular groups. For example, feeding and care needs of children living with cerebral palsy. Ultimately, it's not difficult to understand how to make nutrition policy and programming equity sensitive to disability needs if some careful thought goes into this. But this is certainly a neglected area for a great deal more need for research and further advocacy and action. And I think that's why this seminar today has been so helpful towards this end. So thanks once again for having me